I'd like to turn the floor over to Dr. Wen, who is our moderator for today and will be providing opening remarks.
You notice that they did not say that I'm a specialist in technology, so let's see if this works. Can you all hear me, or is it reverberating strangely? Is this okay? All right, so I want to say, first of all, good morning, good afternoon. Thank you all for coming today. And I want to give a special thanks to our student organizers. I was very impressed when our organizers first contacted us. I believe that at the time it was called the Hippocrates Medical Review. Now the name has changed to the, what if I hold this instead? Is this better?
Yeah.
So, and I heard that the name has changed to reflect another great in modern medicine, William Osler, but I want to thank, and I want for our organizers to please stand up. So Pavan, AJ, Rushabh, Sachin, can you all stand up? Let's give them a round of applause for bringing us together. Now, I'm also thrilled to be joined today by three of my colleagues, friends, people who inspire me and who do great work here in our city and across our state. I'll be introducing them in a bit more detail as they speak, but they are Dr. Peter Beilenson, Dr. Josh Sharfstein, and Dr. Michelle Gourdine. Let's give them a round of applause as well. So our format is going to be as follows. I'm going to give brief opening remarks, and then each of our panelists will be speaking for about 10 minutes on a topic that I believe that our students have worked out with our past commissioners and public health leaders. And then we have free time for Q&A. Now, I am prepared to ask a whole lot of questions. I know that our organizers are too, but we really want to engage in conversation with each and every one of you. So nothing is off the table. Feel free to ask us about career paths, careers in medicine and public health, about ongoing issues, policies, anything else. So with that, let me start with a quick reflection of where we are in terms of public health in Baltimore City. Now, I was told by our organizers that our theme for this first Osler Symposium is health, equity, and justice. I was very glad to hear about this theme, and in particular, that we use the word health and not health care. Because so often we understand health to be what happens when you are in a hospital. But actually, that's not what determines how long someone lives or how well someone lives. It's actually quite a humbling realization for a lot of us who went to medicine, because I think a lot of us go into medicine thinking that we can influence that. But if we look around Baltimore City, and I don't have any slides, although if I had a slide showing the map of Baltimore with the life expectancy, or infant mortality, or cancer deaths, or cardiovascular deaths, you'll see that no matter what legend we use, that same map is going to be there. Meaning that there are neighborhoods, for example, where the life expectancy is 65 years versus 85 years. Those same neighborhoods are also going to correspond to areas of the greatest infant mortality, of the greatest deaths from cardiovascular disease, and really from anything else. And of course, that also correlates with poverty, with lack of education, and everything else. And so, I mention this because we also know that we have incredible medical institutions in our city. We've got Johns Hopkins, University of Maryland, and so many others. And health cannot just be about health care, or else we would have the best health outcomes of anywhere in the world because we have these institutions. So I'm glad that we're not talking just about health as health care. I think something else that will be reflected in the comments from today too, and I know that all of you know this, about social determinants of health. Now, one of the things that I'm going to ask all of our panelists to address is how we all got here and what is our career path. And I want to mention an anecdote from my career, which is that I always thought my dream, I was one of those annoying people who always knew that I wanted to be a doctor. And I knew for a long time, and I never came up with a good answer when somebody said, why do you want to be a doctor? How long have you known? I was, as long as I know, which is kind of a boring answer, but it's the truth. But when I entered medical school, I became very disillusioned. And there was one particular patient who made me disillusioned, who was an 8-year-old boy who I got to know very well during my pediatric emergency medicine rotation. In the ER, if you know someone very well, it's not really a good thing because there's a reason why you know them well. They come in all the time. And I saw this 8-year-old all the time because he came in with one thing. He came in with shortness of breath. He was coughing, he was wheezing, he had difficulty breathing, he had asthma. Every time I knew what to do medically, which is that I could give him an inhaler, nebulizers, steroids sometimes, maybe sometimes I would do a chest x-ray, sometimes he was just fine and we were able to discharge him after observing him. But he would be back the next week, the next month, sometimes multiple times in a week. And it was because there were other things going on. He and his mom were homeless, and they were in between different people's homes where maybe other people smoked. At some point, they lived in a shelter. At some point, they got moved to a row house where even though their individual row house was fine, they were next to apartments that were vacant. And who knows what kind of molds or allergens were there. And that row house, by the way, was also next to an incinerator that was spewing out all kinds of other things too. And so, I think that it made me disillusioned with medicine because as much as I wanted to, I couldn't influence those other things that were going on. And it really made me question this narrative that exists, which is this pervasive narrative of choice. We talk about choice, but we have to recognize that that choice is based on privilege. And I think that's what public health seeks to do. It seeks to level the playing field so that we're giving every child, every person, an opportunity to thrive. And we're influencing all those other factors like poverty and housing and joblessness. All these other things tie into health and vice versa. Now, sometimes when we talk about social determinants and we talk about how many things influence health, sometimes we get to a point of us thinking, what can we do? Because I, in the clinic, I can't find this person housing. Right? I mean, I'm limited in what I can do, and sometimes we feel like we have nowhere else to turn. And so if it's any lesson that I hope that all of you will take away today, and I'm sure my colleagues will say the same thing, it's that there is a call to action for us to start somewhere, wherever we can. So I'll give you 3 examples of what we have done in the Baltimore City Health Department, seeing the issues that exist. The opioid epidemic. We have twice as many people in our city dying from overdose than dying from homicide. Last year, over 700 people in Baltimore City alone died from overdose. Seeing how many people are dying, back in October of 2015, I issued a blanket prescription, which is a standing order, also called a standing order, to every resident in our city for naloxone or Narcan. Kind of scary to write to sign your signature on 620,000 potentially prescriptions, but as a result of training everyone in our city, not just police officers and first responders and EMS, but all of our residents, everyday residents have saved the lives of over 1,600 of our fellow residents. I don't know, and I know that Peter and I have talked about this in great detail when I came to speak at your class, but I don't know another job that I could have where I can look back at 2.5 years and say, as a result of a specific policy change, and as a result of my team delivering these services with our partners, we've saved over 1,600 lives. I mean, that's pretty incredible. Second example, I want to give you, this is a partnership that I worked on, including with Dr. Sharfstein and Johns Hopkins, is that we saw how many of our children in Baltimore City were missing something as basic as glasses. I wear contacts and glasses, I know that some of you do too. But we found that up to 10,000 of our students didn't have glasses. They may have gotten eye screenings, but maybe their results were not conveyed to the parents. Maybe the parents didn't have insurance, maybe they didn't have a way to bring a kid to the doctor's office, but whatever happened, we had thousands of our kids who didn't have something as simple as glasses. Now, I'm all for research, but we know that if kids can't see, they can't read. And this is a basic intervention that can make a big difference. And so together with Johns Hopkins, with city schools, and with many of our partners, we started a program called Vision for Baltimore, that within 3 years, we are going to be able to get eye screenings and glasses to every child who needs them in every grade, K through 8, without the child having to pay, and without having to worry about transportation because it's delivered through a mobile van that's going to be at each of these schools. Again, an example of something small that can make a big difference. I want to give you a last example, which is around childhood obesity. Childhood obesity seems like a big issue, right? I mean, and there are many different contributors to it, but there are simple things that we can potentially do. And I'm very glad to announce that on Monday, just this past Monday, 4 days ago, our city council passed legislation that we've been championing for years. They passed it 15-0 to replace the default drink in sugary drinks, in kids' meals, to no longer be a sugary drink. So right now, if you go to a restaurant, you can actually, the default drink in many restaurants is a soda. That's crazy for kids, right? I mean, we're encouraging kids to drink sodas, and actually parents have to pay extra if they want water or milk. And so this bill is aiming to switch around that so that we're making the healthy choice the easy choice. Again, seems like a small intervention, but small interventions can make a big difference. So as I introduce my colleagues, friends, and other folks who worked in public health, I hope that you'll see in their stories too, why public health and the policies that we're setting and the services that we're delivering can make such a big difference. And again, our colleagues are going to be each sharing their stories, their advice for students, and also speaking about the specific topics as recommended by our student leaders. So I first have the great pleasure and honor of introducing Dr. Peter Beilenson. I said to Peter earlier that I've been in this room in Gilman 50 3 times before, and all 3 times, now all 4 times are with Peter, because the reason I was here before is because of the class that he was teaching. So I'm really glad to be able to introduce Peter now. Actually, as I introduce Peter, I'm also going to introduce 2 of my colleagues at the health department, and they are Amy Burke, sitting in the front row, and Rintan Lowengrath, who's my special assistant. They're both Baltimore Core Fellows. If you want to know more about Baltimore Core and joining us, you're welcome to ask them later. They'll also be passing around a sign-up sheet for those who are interested in the work that we're doing at the health department. But Dr. Beilenson is someone who knows the Baltimore City Health Department very well. He served as the health commissioner for what seems to me a very long time. I've been in my job now, this is entering my 4th year, but he was the health commissioner for 13 years, I believe, between 1991 and 2005. He was then the health officer for Howard County between 2007 and 2012. He's also done remarkable things in his career, including running for elected office. He ran for Congress in Maryland's 3rd District, and currently is a candidate, is that right, for 3rd District? Okay, and also for the, and is currently a candidate for the school board in Baltimore County. He's an author, he's a professor at Hopkins, and among the many things that I admire about Peter, he also set the vision and founded and was president and CEO of Evergreen Health. And so Dr. Beilenson can tell you about many topics, but today he's going to be talking to us about evolution and role of health insurance. So welcome, Dr. Beilenson.
Nice to see you all. How many of you were in my class? I recognize most of you. Okay, so some of this will be repetitive. But it's a pleasure to be here with my favorite longtime colleague, Michelle Gourdine. We've been working together since 1992, 3? 5. I started in 92, she started in 95. She's my colleague from Baltimore County. And the 3 of us will probably be saying the same things. Where the first time the 3 of us have been together, the 3 health commissioners, the 3 last health commissioners, most recent health commissioners with one exception, who wasn't that good. You didn't hear that. And we're basically the same, we'll probably say it's basically the same thing, except that we're 10 years apart in age, from me to him to her, and they get smarter as they go along. So Leana gave my basic story. I started out in a classroom like this at the School of Public. Well, actually I'll start back a little bit earlier. I, like Leana, wanted to be a doctor since I was 8 years old, one of those nerdy kind of fellows. And we taught CPR when I was 16 or 17 and worked on rescue squads, et cetera. I went to college and then medical school. And when I was in medical school, I had a similar realization or epiphany, whatever you want to call it, when I was seeing patients over and over again that had obviously preventable conditions that were preventable had they been dealt with earlier on, and instead we were dealing with them in a secondary or tertiary fashion. So a quick example, I was at Emory Medical School and Grady Hospital, which is the poverty hospital, if you will, for Atlanta. And I came across a fellow in the emergency room 3 separate times, just like the pediatric asthma patient. This was a guy who had stab wounds 3 different times, 2 months apart. And in talking with him, he ended up being in the drug trade. This was related to drug-related violence. And I came to the conclusion that we could continue to sew this fellow up, or we could potentially do something about his drug addiction problem. That was one case. And then I also noticed in seeing patients with chronic conditions, there was a lot of COPD, chronic obstructive pulmonary disease, which is predominantly because of smoking. And I came to the same conclusion as Leana was saying, that if I could work on smoking prevention programs, you could prevent more cases of COPD and lung cancer and potentially save many, many more lives than if you try to get every individual that you had smoking, treating everybody individually who had a smoking condition so that you could do things upstream much more effectively. So because of that, I switched to preventive medicine residency at Hopkins and was happily working in school health when one day a gentleman named Kurt Schmoke, who was the mayor, called me out of the blue. I was 31, well I was 32 actually. I was the youngest health commissioner in the United States history, I think. Well, no, in the last 100 years. Until Leana beat me, she came in at 31. 31 or 32.
I think I was 31 at the time, but I'm old now.
Yeah,
And you guys are really young.
She's 34 or 35, really old. When you get to be my age, you realize that that's not so old. Anyway, he picked me out of the blue. I was literally just out of residency and named me health commissioner. And so I went from being the intern in the health department, literally the intern, to going up to what was then the 8th floor. It's now a parking garage. Being named health commissioner with a $250 million budget and 1,300 staff. So I had to learn on the seat of my pants, basically. And did a lot of fun things. Some of the things, like we started an Narcan program back in 2002 called Operation Staying Alive. We had Operation Save Kids in terms of dealing with juvenile violence. A lot of things that Josh then did bigger and better things, and Leana has done bigger and better things as well. But I think if there's one philosophy or thing that we have in common, is that we're willing to kind of buck the status quo. And that's what you got to be able to do in public health, and Michelle has done that very much as well. So that's sort of my story. I ran for Congress, as my class knows, and came in second, close but no cigar. I'm not a very good politician, although I like speaking out on issues as much as I possibly can, and potentially can maybe win the school board race, which would be very fun. And then I ran Howard County Health Department, which is basically shows the social determinants of health are particularly real, because I went from serving the 5th poorest jurisdiction in the United States to the 3rd wealthiest jurisdiction in the United States, and they're 12 miles apart. And my job went from extremely interesting and challenging to frankly pretty darn boring, because Howard County is a lovely place. It's got nice schools, and it's got healthy people, and it has the 4-legged stool. So I'm going to close. How much time do I have? 5 minutes. I'm talking fast. So another one we talk about in health insurance, but I'll touch on that. But as Leana was saying, the social determinants of health. So in my class, I talk about this paradigm of the 4-legged stool of components that are necessary for a healthy community writ large. So health writ large, it's accessible basically community. It could be a neighborhood, it could be a county, it could be a city, but it could be a state. And those 4 components are safe and affordable housing in nonviolent neighborhoods. Second is access to health care and healthy foods. Third is a solid public education system that prepares kids for the 21st century economy, not the 1950s, and poorly at that. And making sure that the jobs, livable wage, not minimum wage, but livable wage jobs are available and accessible to adults in a community. And just like you have a 4-legged stool, you need all 4 legs for it to be sturdy. If you have 1, 2, or even 3, they're either wobbly or they can't stand up. And far too many areas in Baltimore City and Baltimore County for that matter, where 45% of the school kids, you'll be interested to know this, 45% of the school kids live in poverty. So Baltimore County is often viewed as sort of the suburban area surrounding Baltimore City that's well off, but actually 45% of the kids, 45.1% to be exact, are living in poverty. So you need to address all these issues, and I'll just touch on a couple things and then turn it over to Josh. I guess he's next. So I was at the school board teachers union endorsement meeting last night, and probably the most important question and the most frequent question I was asked is, how can the schools deal with the kids that are coming in not ready to learn? And so I was able to use my four-legged stool, which, as my class knows, I ask all the time and talk about all the time. So that was a valuable lesson that it's not just healthcare that deals with social determinants of health. It's all sorts of arenas in the civic life. And I'll just stop there because I don't have time to talk about the insurance world.
You want to?
Well,
Sure. You're welcome.
I believe in a single payer. That's my one statement on the insurance world. Having run an insurance company, Evergreen, which is a nonprofit health insurance company with primary care system attached to it, it became very clear to me that the way I felt about a single payer was I felt even more strongly after running an insurance company. There are just far too many incentives that are perverse incentives to hold off on care, to delay things, to not do things in the best interest of the patient, even with a nonprofit health insurance company, because you can't run deficits consistently. You've got to bring in your revenue. And it's just far too many perverse incentives in the current health insurance system to allow that to continue. I very strongly believe in a single payer system, potentially Medicare for all, but not run by the federal government. My class knows why. Funded by the federal government, but run by nonprofit, kind of like Medicare does regionally with a third-party administrator that's a nonprofit organization. So I'll stop there and turn it back to Leana.
Thank you very much, Peter. No, there's something that I was going to say in Peter's introduction that I forgot, but he reminded me when he talked about how public health and the work that we do is about bucking the status quo. I think the work that Peter did at the time that he started the Narcan program, and especially with needle exchange, is remarkable. I mean, I have people now, and in fact, there is a bill in front of the state legislature right now that says that if you get revived by Narcan, you have to pay back the taxpayer contribution to Narcan, and if you can't, you go to jail. And then you're forced into rapid detox. I mean, there are still these horrible misconceptions that happen because people think that you're making a choice to use drugs. I mean, I can't imagine the things that were said about needle exchange when you all first started doing this program. And so to buck that trend and to say, look, we're not trying to enable people to use drugs. We are here in public health to save lives. I mean, I think that was remarkable. And Josh and I are fortunate to follow in your footsteps because you have laid the groundwork for what progressive public health can do and why it's all about, at the end of the day, it's about saving lives and improving our community. So really, thank you. Now I'm delighted to introduce Dr. Josh Sharfstein, who is the Associate Dean of Public Health Practice at the Bloomberg School here at Johns Hopkins. He was also formerly the Baltimore City Health Commissioner. In addition, he served in a number of different capacities.
It might hit your head.
It might hit my head, okay. That's bad for public health.
Yeah.
All right. All right, Josh was also the principal deputy at the FDA. He was the health secretary in Maryland. He can give you a lot of different comments about these, including how not to die from a head injury today. But Dr. Sharfstein is going to be talking to us about drug pricing and regulation of pharmaceuticals.
Great.
Then a confession.
And I have to follow Peter again. So one of the first things people told me after I accepted the job of being health commissioner in Baltimore was that it's really important to follow someone who did a really terrible job, because then you look good by comparison. And so they said, what was your predecessor like? And I was like, uh-oh, that's a problem. But I actually learned very much the opposite. People tell you it's good to follow somebody who didn't do a good job, but then people really just have a negative impression of the agency. You're kind of always trying to overcome the expectations. When I started in the health department, all kinds of crazy things started happening. And people came in the city, and people came to the health department and said, well, what are you going to do about it? I was like, I didn't know that was part of my job. I was like, well, you know, Dr. Beilenson would have done something about it. So people, of all the different legacies, and Leana mentioned a bunch that he left, the most important from my perspective is that people in Baltimore see the health department as part of the solution and not part of the problem, which is not the case in a lot of other places. And they see it as a real place for innovation. And that allowed me to do different projects, and I'm sure it allows Leana with her tremendous leadership to do different projects as well. And it allowed state leaders like Dr. Gourdine, she was at the state when I was in the city, to really rely on the health department for different aspects. So, we're all working on a lot of different topics, but I thought this would be an interesting one to focus on because it's a little unusual. We talked about the intersection between healthcare and health. And so some people think, well, drugs are on the healthcare side and health is in all these other areas. And, I certainly agree with both Leana and Peter about the impact of these social factors in health. And it's also the case that for me it was housing that made a big difference. When I was a pediatric resident and I was very involved in advocacy and other efforts around housing. But one of the things that surprised me when I got into public health is you don't leave healthcare behind. And so I'll just tell a couple quick stories about that. So I started as the health commissioner on December 11th, 2015. And on January 1st, 2016, the prescription drug benefit for Medicare was kicking in. It was the first time there was a prescription drug benefit in the Medicare program. Medicare serving mainly older adults, but also disabled. And part of this program was, it was a good new benefit. It was a private benefit, so these private plans would be offering, everybody was assigned to a private plan, and you could pick a private plan to get you drugs. One of the things that they did to make the pharmaceutical industry happy in passing the law was they said that patients who right today are getting drugs through the Medicaid program would have to switch to this new privatized program. A certain group of patients, in Baltimore was like 28,000 patients, they were on Medicaid and Medicare together. They're called dual eligibles. They're some of the sickest, most vulnerable, chronically ill people in Baltimore. People with seizure disorder, psychiatric disorder, diabetes, and they would go from a system where they could get any medicine at any pharmacy to only certain medicines at certain pharmacies. And that change would happen at midnight on January 1st, about 2 weeks after I came in. Now, I came from Washington, I was working for a member of Congress, and I knew that there would be this kind of crazy transition. But when we got to Baltimore, people really weren't talking about it. It was like, well, that was something the federal government was dealing with. So in my first 2 weeks on the job, I convened people in the health department. I said, what should we do? And people said, well, we could have a 1-800 number for people to call if they can't get their medicines. But it's like, for 28,000 people, how do we get the word out? And then someone at the health department, and there's so many great people at the health department, said, what if we backed up pharmacies? And I said, what do you mean? Well, there are 125 pharmacies in the city. We could be the backup, and if the pharmacy can't help the patient get their medicine, if they come in under these new rules, we'll pay for the medicine. So we got students, they were carrying a beeper around, and within 2 weeks we stood this up, and there was an article that said there are Chicken Littles in Baltimore, thinking the sky is gonna fall on January 1st. Then January 1st came, and it was a complete disaster nationally. People couldn't get their drugs, we were paying for it. We had a lot of national attention to what we were doing. This was I think the story in the LA Times. And we wound up helping, I think maybe 100 or so seniors who otherwise couldn't get their medicines. But we also learned how to get the system to work, and we would send all these fax updates. There's this machine called a fax machine. The fax updates to the pharmacies that told them how to use the new system and get it to work. So even though it was we monitored the impact by looking at emergency room visits for older adults to see whether people were showing up for things like diabetes or high blood sugar that could be a problem if they weren't getting their medicines. Now, this is another pharmaceutical, right? Vaccines. And vaccines, generally considered one of the most successful public health interventions, have prevented millions of illnesses, hundreds of thousands of deaths in the United States and millions around the world. So the public health department, has efforts to promote vaccines. Baltimore is one of the most highly vaccinated cities, very strong public health team that delivers vaccines in addition to a really strong pediatric network. But when I started at the health department, there was a big attack on vaccines around that time in this country. There were people who had believed some of the research that was later retracted about vaccines might cause autism. And they had come into Maryland and they were proposing laws that would have made it illegal to vaccinate under certain circumstances. So as the health commissioner, this was a pharmaceutical issue, but it was very much a public health issue. It's another example of how these cross together. And I had to go down to Annapolis and very strongly testify and try to defeat the bills, explain this to people, because I didn't want and them putting all these kids' health at risk. At one particularly memorable point, I was testifying in front of some of the people who were kind of claiming that vaccines were unsafe. And I said, in 2004, Institute of Medicine released a definitive report looking at all these allegations. They found the evidence favors rejection of these hypotheses. This is the scientific view. And I thought, okay, that was my main point. That's why I drove down to Annapolis. And then I was sitting there for the next panel, and someone said, isn't it interesting that Dr. Sharfstein mentioned the 2004 report of the Institute of Medicine? Pretty interesting he didn't mention the 2005 report, where they said that vaccines were dangerous and could cause autism. There's no 2005 report that said that. Oh, Dr. Sharfstein tried to pull a fast one on us. And I had to go to the president of the Institute of Medicine and get him to write a letter to every senator who was there and say that was complete baloney. But just to give you a little bit of a sense. Of course, nobody now is raising questions about vaccines, so it's still an active issue. Very briefly on addiction, one of the things that we picked up was making addiction treatment more available. That's a pharmaceutical we use, buprenorphine. We had something called the Baltimore Buprenorphine Initiative that we started, where we treated thousands of people with an effective treatment and saw a very steep decline in overdose deaths. Between Peter's time and mine, there was an 80% decline in heroin overdose deaths in Baltimore City. And it was really directly linked, this is a paper from the American Journal of Public Health, to the investments that were made in treatment in the city. Pharmaceutical treatment, generally supported by other services, method of buprenorphine, very important. I think this is my last one. There's something in Baltimore City called the Child Fatality Review, where the health commissioner every month sits and hears about the unexplained cases of death among children in Baltimore City. It's the most depressing meeting you can possibly imagine, particularly as you realize cases where there are warning signs that were missed. This is a case of a child that came with a cold and a fever to the emergency department. We won't go through all the medical parts, but basically was handled perfectly fine by the emergency department, got the right medicine, went home, came back dead the next day. And on the autopsy, it showed an overdose of cough and cold medicine. And in fact, when we went back, and Peter might have called me, there were other cases, overdose deaths from cough and cold medicines, which I knew as a pediatrician actually had no evidence for effectiveness. And so we started by issuing a statement. We had all of the Baltimore hospitals, pediatrics departments come together and issue a statement urging parents never to use these medicines. Like, used to be these little cough medicines and little babies on the vials. Never to use them for kids under 6. And then after that, we did a petition to the Food and Drug Administration asking for them to come off the market. Got a lot of national attention. The FDA agreed to take it up. A week before a big meeting, all the drugs for kids under 2 came off the market, and after we won the advisory committee vote, all the drugs for kids under 4 came off the market. And there have been follow-up articles showing dramatic reductions in poison control calls and emergency department visits from overdoses as a result of that. Again, kind of unlikely pharmaceuticals and public health. So just a little bit of an insight. This is just one issue, one set of issues that we worked on. But medicine and public health have a lot of overlaps, and in both ways, good and bad, pharmaceuticals and public health intersect. Thanks.
Thank you very much, Dr. Sharfstein. So I think that he illustrates well for us why we do the work that we do. That in public health, we have the opportunity, when we see a problem, we have the opportunity to intervene. And we can intervene because we need to intervene because these are lives potentially at stake. And if we can prevent another child from dying or individuals dying from overdose, then we do that. So I am now glad to be introducing our final speaker before we go to your questions, who is Dr. Michelle Gourdine. She is a primary care doctor. She is the former health officer for Baltimore County. Also the former Deputy Secretary of Health in Maryland, as I learned today, because I thought that she was still doing a lot of other things that she did before. I won't mention all the other things that she's done before, but she is now the Senior Vice President for Population Health and Primary Care at the University of Maryland Medical System. Among Dr. Gourdine's other many accomplishments, she also is the author of the book, Reclaiming Our Health Guide to African American Wellness. She's internationally recognized for her work on race and health, and she'll be speaking about that today. So, Dr. Gourdine.
Thank you, Dr. Wen. Thank you, everybody. It's a pleasure to be here and speak to you guys today. So I'm going to zoom through these slides very quickly. I got a little slide happy here, but in keeping with the trend of how we got to where we are, that's where I started out. Actually, officially was born in Washington, D.C., but I don't remember that. I was raised in Mississippi and went to this school here. It's a historically black college in Mississippi that was very prevalent back in the 1960s in sheltering freedom riders, people who came from the north down south to protest civil rights issues in Mississippi, which unfortunately had a pretty negative reputation at that point. My dad actually was a civil rights attorney in Mississippi at the time. Ended up in this area, moved here in 1984 to go to that school. Some of you may recognize that as the Dome for the Johns Hopkins Hospital. Did my medical school and pediatrics training there. Unlike Dr. Wen and Dr. Sharfstein, I didn't decide I wanted to be a doctor until I was in high school, so I was a little bit of a slacker. Hope you forgive me for that. But did medical school and pediatrics residency and then practiced peds in East Baltimore for a time. Actually went back to Mississippi for a couple of years and practiced pediatrics as well. Dr. Wen and I were just talking about the different perspectives you have after you have kids. I thought I knew everything about children when I was a pediatrician, and then when I had children, I learned that I knew nothing. After that, in 1995, which is when Peter and I met, I was 32-year-old, there's a trend there, 32, health officer for Baltimore County. And Peter, one of the biggest challenges I had in the 10 years I was there was to make the point that you made about 45% of children living in poverty. I had to make the point that every social ill, including crime and poverty and the like that occurred in Baltimore County, did not migrate from Baltimore City. Folks who actually were working in county government at that time had the sort of incorrect notion that that our county was not plagued with poverty issues or drug issues or crime issues, and to the contrary, yes they were. And so won't get into a whole lot about what was going on there, but really enjoyed that opportunity to head up a health department. Not quite as large as Baltimore City. We had about, at that time, 450 employees and a $40 million budget, serving a jurisdiction of about 750,000 people. And so that was kind of the journey and the path that I took. And during my career, I've done a bunch of stuff like all of us have, but dealt a lot with sort of race issues and had the opportunity to write the book that Leana was kind enough to mention. So this is my shameless plug. And I have to say Dr. Sharfstein has recently written a book as well, which will be coming out in June. What's the name of it, Josh?
Oh, I don't remember.
Oh,
no, I'm just kidding. Public Health Crisis Survival Guide.
Public Health Crisis Survival Guide. It is available for pre-order on Amazon. Josh, you need to do this in every lecture that you give from now on. He's paying no attention to me. But no, seriously, I'm looking forward to pre-ordering my copy, and you guys should do the same. So, I was asked to talk about racial issues in health and given 10 minutes, which is totally unfair. So I will do the best that I can. And here we go. We all know racial disparities are well documented. Anybody who doesn't believe that, you know, you're wrong. And this is just one slide I want to show you, looking at age-adjusted death rates. This is back in 2014, so the data's delayed a bit, but clearly when you look at the incidence of death rates for many of the major chronic diseases, you see that certainly the blue bars, which represent Hispanics, African Americans, and Alaskan Natives, and I don't know what the other AI is. Anyway, there is a disparity there in terms of death rate, which reflects the disproportionate impact of chronic disease and other conditions on minorities and certainly African Americans. So health inequities, we know, stem not necessarily from biological faults and genetic faults, which may surprise you, actually were a part of a good bulk of the literature that came out probably in the 50s and maybe even early 60s. There was some genetic and biological fault that African Americans had that made us more likely to be affected by disease. That clearly is not true. We know that. We do know that societal inequities play a role in health, and we're going to talk about the second bullet, the distribution of what I call resources that are needed to be healthy. We'll get into that quickly. So this is sort of a graphic that demonstrates many of the factors that lead to disparities in disease and death, including root factors like poverty and oppression and racism. We're going to talk about and focus on racism, but also environmental factors, access to health care, and of course, certainly, I'm not discounting the impact of biological issues as well. So this is a study, Arlene Geronimus has done a lot of studies on what she calls weathering, what is known in the literature technically as allostatic load, which means the wear and tear on the body that come from constant and persistent exposure to stress and lead to increased risk for all types of chronic diseases. And basically, she was talking about the weathering effects of living in a race-conscious society and the impact of those effects on individuals' health. And she looked at the impact on African-American health and found that especially African-American women were affected by that. So again, this picture is of a weathered building. We all know that, when buildings are exposed to the elements like the wind that we're having today and the rain and all of that, you do begin to see a sort of chipping away and a wear and tear on the building's exterior. In the same way, you can think of that sort of chipping away at the resilience and the ability of an individual to fight off risk for disease. The cumulative effects of sort of that wear and tear accelerate aging and increase risk of early onset of disease, and that is what we actually in fact see. This is the cover of Essence magazine, which is looking at African American women of all ages, 20s, 30s, 40s. There is a phrase in the African American community, so I'm going to teach y'all something today, that says black don't crack. What does that mean? Basically what that means is that we as African Americans say that because of our the tone of our skin, our dark skin, in some regards, the melanin in our skin protects us from premature sort of wrinkling and kind of the exterior sort of signs of aging. However, does not protect us at all from the internal effects of stress and racism on our health. And in fact, this study was done and revealed through looking at, I'm not going to get too deep in the weeds, I've got 2 minutes, looking at certain effects on the length of telomeres, which are part of chromosomes, that middle-aged black women are biologically 7.5 years older than white women due to prolonged stress, which means that what you would expect to see in an older person in terms of onset of disease certainly is seen earlier among black women. So let's look finally at residential segregation. This is fascinating stuff, and I could talk about this for a long time, but I just want to show you a few slides. This is actually courtesy of Baltimore City Health Department many, many years ago, but I like this slide because it depicts, based on the colors in the slide, the life expectancy and a disparity in life expectancy within a very short distance of time. So for example, if you look at the darker areas which are to your left, which represents sort of central western Baltimore City, the life expectancy is 20 years less than an area perhaps 5 miles away, sort of in north central where you see the Ruxin area. And so pretty remarkable that your zip code really does determine your life expectancy. Actually, let me go back, and I'm gonna assume that Peter didn't use all his time, so I'm gonna take one of his minutes. So this is really important. Residential segregation is something that occurred across the country, was certainly prevalent here in Baltimore City, and I want to rest on this for a minute because it has, although it happened way in the past, it has effects on present day. So what are we talking about? Government-sponsored segregation, that limited and restricted areas of the city where African Americans could live, and even restricted areas where whites could live, because whites and African Americans were not allowed at that time to live in the same areas of the city. Although this was a city ordinance that the Supreme Court deemed unconstitutional in 1917, practices persisted in Baltimore. Code violations were issued to people. There were contracts that prohibited blacks from purchasing homes in certain areas. And the mayor of Baltimore at that time explained his persistence this way. He said blacks should be quarantined in isolated slums in order to reduce the incidence of civil disturbance, to prevent the spread of communicable disease, and to the nearby white neighborhoods and protect property values. That was his explanation. What happened after that was something called redlining, which some of you may be familiar with, which basically was endorsed by the FHA and said that certain borrowers who live in certain areas of a town or a city that were considered to be unfavorable risk were not able to get loans to purchase homes. As you can imagine, those areas that were redlined, and let me show you this slide. The red area, this is Baltimore, the red area of that slide represents what they call the fourth grade or the D area, which is an area of highest risk with, quote, an undesirable population and a low percentage of home ownership, specifically for the reasons outlined in this previous slide, that those individuals were not able to take out loans. And so what has happened is that the rate of home ownership at that time was low. If we look at the impact on present day, we know that many individuals who have generational wealth now and household wealth, so generated that wealth over decades due to home ownership way back when. And so as you can see, currently because of redlining and the other sort of residential segregation effects, household income is, for African Americans is only about 5% of that for whites. And so finally, actually before we get to this last slide, let me just emphasize this. Communities are separate but unequal. You've got unequal access to the four-legged stool that Peter was talking about, which directly impacts health. This slide, I love this slide. This is fascinating, and you can find like these residential segregation maps online for any city you choose. This is Baltimore. The green dots are black residents and the blue dots are white residents. We no longer have redlining. We no longer have ordinances that prohibit segregation, integration of communities. But look how segregated we still are. Look at the confluence of the green dots with very little blue, representing the areas where African Americans live, and vice versa. The blue dots represent where whites live. And so I just want to point out that fact that we still have a ways to go in terms of that. And so to summarize, health inequities are persistent, as we know. We see that there are race-based societal inequities that stem from way back when and currently affect health, the economic opportunities, the education opportunities in present day. And so what we have to do is to focus on upstream causes of health disparities. And so with that, I will stop. Thank you, guys.
Thank you very much, Dr. Gourdine. You presented such a clear, I think, picture of this whole zip code mattering more than your genetic code, which is really depressing in some ways, but also is a call to action for us. Because again, I think that public health can be a very powerful tool for leveling the playing field of inequality, recognizing the problems that exist in these persistent disparities. What is it that we can do now? So I invite for everyone to join us in this conversation. As you're thinking about the questions that you all ask, I know nobody wants to ask the first question, so as you're thinking about what questions you want to ask, I'm going to ask one, use my moderator's prerogative to ask a question of all of our panelists, which is that there are a lot of misconceptions in public health. And actually, I was asked this question yesterday in the panel, so I decided that it was a good one to explore today. So, and I'll give credit to them. It was at the Kerner Commission panels, not the 2005 Institute of Medicine, but the Kerner Commission panel yesterday. And the question is, there are many misconceptions in public health and medicine. Talk about one of them and what you would want to do, what you would want for this group to help us to do in overcoming that stigma or misconception? Starting with Dr. Beilenson. Stigmas in public health. Anything about anything. Or in public health. So I can give one. So one that, what I said yesterday, I think, and Rita can tell me if I said otherwise, but what I said yesterday is that I quoted Congressman Cummings, who says that the cost of doing nothing isn't nothing. The cost of doing nothing is something, it just is not always apparent. And so I think it's important for us to speak up when there are policies that are being proposed, and they propose the policies as, here's how much this will cost. But we don't talk about the cost of doing nothing. So if we talk about the cost of Medicaid and health insurance, and we say, well, that's how much it'll cost, but we also need to talk about what happens when we don't have Medicaid, when we don't have health insurance, and what is the downstream effect on kids, on families, and so forth.
So one misperception that I think we've all dealt with is substance abuse and substance abusers being viewed as people who have made a very bad decision and are causing a lot of financial problems and health problems for the society, and that therefore they don't deserve to be taken care of. Leana was mentioning the Narcan thing. I can tell you without disclosing who it was, but a high city official when we launched our Narcan initiative, which is an overdose prevention initiative with the opioid problem, that individual said, why are we bothering to even save these people's lives? They're not going to get any better. They're not going to contribute. And in fact, the 1,600 people that are saved under Leana's program, and we had 500 saves during the time that I was there, that we added up. I've actually met several people personally who've come up to me on the street, either from needle exchange or from Narcan, that have thanked me and thanked us for doing what we're doing, and they have jobs. They have a house, they have a family again, they're paying taxes, etc. So not that that's a specific reason you have to take care of people, that they've got to be totally productive human beings, but you've got to treat people without a stigma.
Peter, maybe you would just say for a second what you did to really show people
I
that.
dressed up. So for those of you who know me in my class, you know I'm a schlumpy dresser. I don't usually wear coats and ties and stuff, and so I dressed down. Although people make fun of me that I didn't really dress down, but I went out to drug addiction centers that in the city, and before I'd been on TV a lot, like all these guys have been as well. And I grew my beard, and I put on glasses and a cap and sweats and a hoodie, and went out and pretended to be a drug addict named, I can't remember what my name was, but anyway, to see how hard it was to get into treatment and how I was treated. And I was actually treated very poorly by the staff at these programs, and we implemented some changes. So anyway, that was fun.
I guess I would say that if you were talking about brain surgery or maybe rocket science, most people don't think they could just think up the answer at home. When you talk about public health, everybody's an expert. Everybody's got an idea, and whatever comes first to their mind sometimes is the thing that people will pursue, just in general, the go-to thing that people want to do is an education campaign. And they see something wrong, and they say that the solution is to just go tell people, if only they knew, that if only they understood that it's what they're eating is doing to them that's making them sick, we've got to have an education campaign. And in fact, they're often going to probably the least effective strategy of all the ones in the toolbox. Because much of the time people know and have no opportunity to do things that are different. And figuring out how to change that conversation is a constant challenge because it comes so intuitively. It reflected a little bit on what Peter said about addiction. It comes up on issues like obesity. It comes up on many different issues. So the solution is just to tell people, get them to change. Why aren't they doing it? And it sometimes comes up within the health department too. You have some money to do something, let's do a communication campaign. And then related is the idea that if you do a communication campaign, that it's what you think would convince you that's the right message. And so I learned this when we had a big challenge in Baltimore with babies dying from being put to sleep in the wrong position. How should babies be put to sleep? I won't quiz Leana right now. On the back, alone in a crib, right? And we had 1 year, 29 babies who died, not on the back, alone in a crib, which is terrible. And we tried to do a whole bunch of things, and the things we started with were all medically based. We trained all the nurses in the hospitals, which isn't a bad thing to do, to give discharge advice. We gave all the babies free onesies that said, if I'm sleeping, turn me over, to make sure. We actually got to the point where every time a baby died in Baltimore, I wrote a letter to the hospital, and I said in the letter, a baby died who was born in your hospital. Please use this letter to pull together all the staff and reinforce yet again the need to educate the parents about putting the baby together to sleep the right way. Didn't work. We did not see any declines. And about that time I hired someone who was trained really in global public health. And she came and she said, you're going about it all the wrong way. You're thinking about it what would convince you, the nurse, that, think about who people will listen to in their lives. And we designed a campaign that was around other voices from the community, including people who had lost babies, looking right in the camera and saying, if I knew then what I know now, I never would have put my baby to sleep in the bed with us. And that caused a shift in Baltimore in how babies were being put to sleep. I think it led to substantial declines. I know it's bumped up a little this year. It went from 29 down to like 8 a year. So that's babies saved per year in the city. And it was because people didn't just project their sort of first gut instinct anymore, that you used the science and you thought about what was actually going on and you thought about some of the underlying issues and not just education.
That's a tough question to answer because there are a number of issues that are going through my mind, but I think I'm going to land on this one. And it actually is not necessarily a misconception about public health per se, but it is a misconception that public health helps to inform the solution to, and it comes from all of our worlds as practicing physicians. One of the things that I hear a great deal from my colleagues, especially who work in areas where there's a prevalence of minorities or individuals of low income, or not, is they see patients, and these are patients who end up, bouncing back to the doctor's office or to the emergency room or admitted and readmitted, and the lamentation goes something like this, they're so non-compliant, they would just do what I tell them to do and then everything would be okay. Which is insulting. And it is also lazy. Because what's important and what we in public health understand, and I think what we need to do in terms of making sure that it's understood in healthcare writ large, is some of what all of us have been talking about today in one form or another, which is sort of going upstream and exploring what things are needed in order to be healthy. One of the many ways I often describe this to my colleagues when we're having these conversations one-on-one is, think about Maslow's hierarchy of need. A good number of the folks that you're talking about here are at the bottom. They're concerned about food, and they're concerned about shelter, and they're concerned about safety. They haven't even made it up to the point where they can even consider what it is that you're recommending. Did you even ask whether or not your recommendations would be feasible to them? Is this something they would be able to do? Is this something that we might be able to provide you some assistance in being able to accomplish? These are the types of things that now that I've sort of crossed over the boundary from public health to health care, I'm recognizing are probably some of the most vexing problems that we have, because in healthcare terms, what these folks are called are high utilizers. And they utilize the most expensive forms of care, meaning bouncing back and forth to the emergency room and to the hospital, and without getting into a whole lot of depth. It's a problem when these patients continue to recur in their visits to the hospital. And one of the things that certainly we can thank Josh for is working with our federal partners to correct the incentives so that we're no longer at our hospitals incenting volume, but we're incenting providing care and getting the right outcomes, which means paying attention to those upstream issues. So
Thank you for indulging me in that. And two things that I want to pull out from what was said. One is around this whole issue of choice. I mean, I talked about this a little bit before, but it annoys me so much when general public talk about, well, people are choosing certain things or choosing not to do certain things, choosing not to follow our recommendations. I mean, when I was working in the emergency department and I had my residents or students come and tell me, well, this person didn't follow their dietary recommendations. Well, what are we asking them? I mean, we're looking around Baltimore City, 1 in 3 African Americans lives in a food desert, where they have to take 2 buses and then walk 10 blocks just to get some type of healthy fruit or vegetable, where the closest corner store, the only thing they have that even remotely resembles a vegetable is potato chips, or a dried old banana is what they have that resembles a fruit. I mean, what is that choice that they may actually have? And so I think a lot of what we do in public health, going back to Josh's point, is how can we recognize that, and how can we make the default choice? So we're not just talking about education, but we make the default choice one that's easier, recognizing behavioral economics and everything else that plays into it too. And to both to Josh and Peter's point about credible messengers, you know, I don't think that I can quite go into our clinics and seek treatment maybe the way that Peter was able to do for Secret Shopper. But I was talking about this the other day with someone about credible messengers when it comes to violence. We have a program within the health department called Safe Streets, where we hire individuals who are from the communities that they serve to interrupt violence. They see people involved in a conflict and they interrupt those conflicts. And it's remarkable, potentially saving hundreds of lives every year, preventing hundreds of gunshot wounds every year. If the 4 of us, and maybe I'll just speak for myself, if I were on the streets of West Baltimore and I told someone, please put down your weapon, I don't think it's going to work very well. But having someone who was formerly a gang member, a drug dealer, who is seen as a credible member of the community who's worked in the shoes that they serve, they can help to reduce infant mortality, they can help to increase access to drug treatment, if the message comes from somebody who is a trusted member of the community. So I need to see questions from the audience, or else the 4 of us will just keep on. Yes?
Hi, this is a question for all the panelists. How do your backgrounds in clinical medicine and clinical care inform your public health practice?
Actually, being a physician has been very beneficial, because you learn more than I think you do. You know more than you think you do, even without having practiced terribly much. I think Michelle practiced the most, Josh second, and me third. I worked in some of our health department clinics and did residency, obviously, and internship. But it brings you some cachet, some credibility, not to be elitist at all, but just being an MD has helped in terms of working with hospitals and doctors. And you know, I know, like I like to say, I know this much about a lot of topics. So you can do public messaging and media stuff and be sort of a trusted messenger to the public.
Go ahead.
Yeah, I agree with that, Peter. I would add understanding the sort of day-to-day of practice and what you're challenged with attempting to accomplish on a daily basis, especially as a primary care doc, when our revenue is generated by volume. So when you go see your primary care doctor, if you're in there 15 minutes, that's a really long time. And then so that knowledge informs public health initiatives and programming and policy, where to Josh's point, everybody wants to do sort of a public awareness and education campaign. And can't the doctors just sit with the patients and talk to them for 30 minutes about blah? No, they can't. They can't. They don't have that time. So kind of a reality check with regard to policies and rolling out initiatives that are clearly beneficial, but we want to do it in a realistic type of way. So that's what I would say.
I'm going to come at the question a little bit differently. I agree completely with what's been said. I would just say, for me, the most what I didn't suspect was that the experience I had with angry parents from a pediatrician would be enormously useful in public health. And there are two, you can divide in my residency program at least, the way pediatricians respond to angry parents. Parents who are really angry that their child wasn't getting the right treatment. Some people took it so personally. they were so angry back at the parent. They would say, I don't want to go into this room. I hate this parent, you know. There's what a jerk. They said I didn't prescribe this right, or that the medicine, it didn't even matter. Why are they so, you know, just so angry. I don't know if it was naturally or I just grew into it. I was like, why is this parent angry? You know, like, what's going on? What's the fear that they have for their child? What's that? And it was like, for me, like a clinical challenge. How do I get in there, try to earn their trust, try to think about what's going on? And I was sort of like, there would be a screaming parent literally in the hospital, and they would page me. I was on a different service. I was a resident. I would come up, and at one point, I had an intern who looked like he was, you know, competing for Mr. Universe. And I mean, he was so, and I did not, okay? So he came to me and he said, we have to call the police. And I said, why is that? He said, well, because his parent just said he was gonna kill me. And I said, well, what did you say? He said, well, I had said before, he said, I had just said that the child was in the emergency department. The child, I know you want to bring the child into the hospital, but there are 4 criteria for admission, and unfortunately your child doesn't meet any of them. So there's nothing I can do, he has to go home. And the parent said, well, if something happens to my child, I'm gonna come back and kill you. And I said, well, let me go down and talk to the parent for a second, you know? And so I learned how to go in there and say, look, I will admit your child, it's no problem, let's just talk about whether that makes sense, what do you think will happen in the hospital, you could go home and call me all night long, whatever you want, you know, hugging me, goodbye doctor, we'll talk to you in 2 hours, you know, totally different. That kind of clinical training, intense, you know, situation, really helps, because when you're in public health, you deal with a lot of people who are angry, people who are justifiably angry, and there's a reason for their anger, and you can't take it personally. I'm sure all of us have been denounced on the radio in one form or another for something that's happened, and if you take it too personally, if you are in that first group, it's really not a great job for you. On the other hand, if you use that and you can come to try to figure out that as a challenge and something that's actually important, it's a key, it's a clinical sign, what's going on. To me, that was the thing that actually made the most difference.
I'll give you an example. The first month that I was health commissioner, we had death threats and a homicide squad at our house for a week. And by the time I left, people were coming up on the streets and hugging me.
That seems like we need to have another story based on that, but you know, let me answer your question, I think in a different way than all 3 so far. I agree. I was told by our organizers that some of you may want career advice, so consider this to be unsolicited, or rather somewhat solicited career advice. But you know, I love being a doctor. I love being a doctor first and foremost. If I had to return to anything, I would go back to practicing medicine, which I still do. I'm trained in emergency medicine. I still do urgent care once a month or so, and I love that. That said, and I came from academia, so I worked with a lot of medical students and residents. My strong advice to all of you who are considering careers in medicine and public health: don't go to medical school unless you really want to be a doctor. I worked with many medical students, even residents, who weren't certain that they wanted a career in medicine. It's a really long career path. It's a hard career path. It's also, there are many other people who want to do this. So if you don't want to be a doctor, please let somebody else have your spot. Now, I know that there are, not everybody may agree with me here. Maybe there are those who, I'm not saying that if you do research, it's a waste of your medical career, or public health is a waste of your medical career. Obviously, there are other ways that you can contribute that make a big difference too. But I'm just seeing so many people apply to medical school or enter medical school who are thinking, well, I don't really like the patient care, the one-on-one patient care. I want to do something else, and medical school will help me do that something else. I would say there are other ways to do that something else. If what you want to do is public policy, public health, you can get a master's in public health, a PhD. You can work in public health and do that too. You don't need to go to medical school just to do that something else. I have colleagues who entered McKinsey, who went into finance and did startup work. They could have done that without going to medical school too. So with a shortage, in a time when we have a shortage of doctors, when there are many people who want your spot, and it's a very long and hard career path, I would really urge you to think twice before you embark on this very rewarding, but also very tough career. But feel free to disagree. Or all of you, feel free to throw things at me if you disagree, or raise your hands for another question in the back.
I do have a question. These are very skilled students, and they might become interested in a body organ in a kind of an abstract way and could actually advance like heart disease or aneurysms or whatever without necessarily being a people person. And these people should go to medical school. You see, there are some pretty awkward doctors out there who don't have social skills, but who are really good doctors, good surgeons, good thinkers. So those should be encouraged.
So I'm reminded by our student organizers actually to reframe the question because we're taping, and so I think that so your question is about maybe there are others who should be doctors because they're very skilled, compassionate, etc. I don't disagree. It's not so much about what skills you have as much as what are you passionate about. I would really encourage all of you to pursue what you are passionate about instead of what somebody tells you, you need to do this education in order to do that. I have a problem with that way of thinking. Not me. If any of you want to be in medicine and whatever skill sets you want to do, great, do it. I just have a problem with someone thinking, in order to get to what you want to do, you need to go to medical school. When that something isn't practicing medicine. Obviously, if you want to be a doctor, a physician, you need to go to medical school. But if you want to do something else, I have a problem with people saying, in order to get to that, you need to go through medical school as a stepping stone.
Yeah, so quick question. So we have the rare opportunity of having a panel that has worked in the Baltimore healthcare zone from 1991 to the current state. So from all of your opinions, how do you think Baltimore has changed in the since 1991? How do you think Baltimore has changed? How has it gotten better? So just one of your thoughts on that.
Well, I'm the oldest one. I started in 1992. I was 32. So parts of Baltimore are sort of gentrified and reconfigured, like Harbor East. So I have I don't know if you guys know what Baltimore looks like. It looks sort of like the state of Nevada. So facing me, it kind of goes like that. And there's a wine glass. So the wine glass is the bottom of the glass that's kind of long and elongated from Canton and in Harbor East to Federal Hill. Then you go up the Charles Street corridor, and then you go out into Roland Park and Guilford and Northeast Baltimore and parts of Northwest Baltimore. And those are the kind of redeveloped areas, the higher income areas, the less vulnerable areas. Outside of that, West Baltimore, East Baltimore, Pimlico, and Cherry Hill, honestly, I don't think there have been that many changes. So I've got to say we do more drug treatment, but crime has kind of come and gone. It's been 350 homicides when I started, and it was 347 or something this year. There are certain things that are better. Obviously, AIDS and HIV are vastly better for a variety of reasons. Hep C is better. Infant mortality went down somewhat fairly significantly, but the overdoses and teen pregnancy is down a lot from when I started. So there are some improvements in health outcomes, but the socioeconomic status of many of these areas has not changed so much. So we're kind of a tale of two cities, to be Dickensian. One has kind of gotten wealthier and more redeveloped, particularly the harbor area, and the other areas are much more like what's depicted in The Wire. Granted, some public health improvements, no question about it, but that's my feeling. The second one.
So, yeah, I'm the second oldest, so thanks, Peter, for reminding me. So, tale of two cities, most definitely. The gap between the haves and have-nots, I think, has grown. It feels that way, and I think that is probably true. There is also a sense, and you guys have to forgive me because I'm a really intuitive person, so I don't have any empirical evidence behind this, but there is also a sense on the have-not end of the spectrum, and that I've noticed in 1984 until now, of growing hopelessness among the have-nots, which to me is extremely alarming and is as much an indicator of future health status, quality of life, as any of the other factors that we talk about here. and it's very, very concerning. That's one thing I wanted to point out. The other thing, sort of disjointed but related, I remain concerned and becoming increasingly alarmed at the, to me, decline in the quality of public education in the city, which to me is probably the greatest, if not one of the greatest indicators of what future health status is going to be like in terms of the have-not end of that spectrum. You know, I'm a firm believer, maybe because I grew up in a family of teachers. I was the only one that went off the rails and went into medicine. Every other female in my family was a teacher, including my daughter. That you shouldn't have to be able to afford to get a good education. And in this town, and it's not unique in many other towns as well, it's increasingly becoming that way. And we know in reviewing the literature of the direct link between educational status and health. And that concerns me greatly as well.
My answer to this is, I'll state my answer and then recognize, based on what our student leaders are saying, that all of you have to go soon to class, which we also would highly encourage you to pursue. But that I think that there has been more recognition to the root cause of issues. And specifically, I refer to after April of 2015. I started my job in January of 2015, so one of the first things that I encountered was the unrest, the riots that followed the death of Freddie Gray while in police custody. And I think as a result of that and the conversations that occurred around the structural underpinnings of inequalities and racism and how we got to where we are, there's at least an understanding that we didn't get here overnight, right? Redlining and all these practices have happened for a long time, but these things have been happening for a long time. And so how can we get at the root cause? How can we get at the social determinants? How can we see someone not just as a perpetrator of violence, but understand that this person also has gone through extreme trauma in their lives? So I think that's a change in the right direction that we need to capitalize on and continue to make progress within public health. So let me conclude and say that for me,
As the youngest person, don't I get to go?
I am so sorry that I forgot. I forgot. I was so excited about the time to make a call for all of you going back to class, because as I recall, Josh, I came to speak at the School of Public Health once and made some kind of comment about how people should not pursue public health degrees. And ever since then, I've been very sensitive about making sure that we emphasize the importance of studying. But Dr. Sharfstein,
I would just say very, very quickly, super quickly, that when you're in jobs like the ones we've had, you develop a real affection for the places that you're working in. And it tugs you when things go wrong. It tugs you. I remember being around and being part of the team that recruited a whole new set of stores to a mall that was going to cause economic development, and then the mall goes down, and you feel it personally. And that's just a very small example, but you get excited about the good things. You see the frustration and hopelessness sometimes, and it really hits you. It is one of the real, I think, great things about public health is that it's just similar to the way the doctor feels with the patient. Someone who does the work feels with the community. And so we feel that question really intensely. It's a long answer, but you can see we all feel it really intensely. And it's something that makes public health such a great career.
I think that's a perfect end to our day today. Thank you everyone for coming. Thanks again to our organizers for this Health, Equity, and Justice Osler Symposium. Thank you.